My name is Altuğ Kasalı. I'm from Turkey, Izmir, Turkey. Uh, I'm a I'm an architect by background, actually. I did my doctoral dissertation, doctoral degree in Georgia Tech. Uh, Graduated some time ago, and my main interest is shifted a bit, but my main interest was in healthcare design. And back in Georgia Tech, I worked with Professor Craig Zimring, and professor. My main advisor was Nancy Nersessian. Actually, she's a cognitive scientist, and uh, Craig Zimring was an environmental psychologist. So my thesis was kind of in between. Now I'm teaching in the School of Architecture in Izmir Institute of Technology, and today I'm going to be talking about uh, the research I have completed back in Georgia Tech. The title is The Role of Evidence in Problem-Solving Practices of Healthcare Facilities Design Teams. And this was a research completed, again, for my doctoral studies in Georgia Tech, where I studied with Craig Zimring and Nancy Nersessian. And my main interest was, the main question was, how do these people coming from diverse backgrounds come together, make decisions, and erect a hospital building, which is a very complex structure building. That was the driving question. And the outline of my talk today is like I'm going to be talking about the evidence-based design framework and the research questions of my uh, investigation and my approach. And then I'm going to be talking about partial findings of my dissertation because it's a really large document. It was a qualitative study, but I'm going to be only talking about some parts of it, which I hope makes sense. And I'm going to finalize the talk again in no more than 30 minutes. So I start by framing the complex link between research and design, or architecture, if you call it, partly due to the conflicting epistemologies of these domains. The relationship between scientific research and design has often been discussed in literature and in the context of architecture, for instance, and I quote, repeated efforts have been made by the profession of architecture both to filter and repackage information in order to make it more easily usable, as well as to restructure architectural education in order to make designers more scientifically literate. So even though designers or we call it architects are considered to be the target community to utilize scientific research, there is a significant number of cases reported in literature to demonstrate that architects do not engage with scientific research findings in a meaningful way and rarely apply them in practice. That is the context that gives rise to the approach that we call evidence-based design, and which is a new trend actually. And what I observe is that it is very common in and widespread in the States, not that much in Europe, I would say. Uh, this is a new trend, or maybe you call it a recurring theme. And what I'm talking about is the efforts to establish stronger links between scientific research and design. The literature demonstrates that there's a growing body of scientific studies providing relevant evidence to support design decision-making processes in architecture, in urban design, in landscape design, interiors, you call it. And there are also emerging institutions or organizations like the Center for Healthcare Design that try to link academic research to professional design practice or professional design communities. Following the framework called evidence-based practice, a certain vision is promoted where academic caliber investigations providing scientific evidence to guide design work. So for some, we are living in the era of evidence-based practice. Starting in the early 1990s, the bold assertion of evidence-based practice within the field of medicine gained significant support. Commitment to evidence-based practice is increasingly being transferred to a range of disciplines such that we can now speak of areas such as evidence-based policy making, evidence-based education, and of course, evidence-based design. So the evidence-based practice has its roots, obviously, in the field of medicine. The theory comes from the field of medicine. The introduction of theory of evidence-based medicine can be traced back to 1990s, although one can argue for an extended history for the idea that goes way before 1990s. The epistemological stance behind this proposition, framework, or theory, you may call it, is the notion that evidence is associated with the outcomes of rigorous scientific research. The new paradigm, as proponents call it, deals with the uncertainties of clinical medicine by introducing extensive use of evidence emerging from clinical research. Typically, in evidence-based medicine practice, the uncertainties are eliminated by making use of research findings according to various ranking schemes, hierarchies, which partly eliminate the question of what evidence to utilize within a certain situation, be it a diagnosis or a treatment process. So in other terms, it is giving you an algorithm to follow in designs or in practice. According to Kirk Hamilton, very prominent figure in the field of evidence-based design, EBD is the natural parallel and analog to evidence-based medicine, and it is the deliberate attempt to base design decisions on the best available research evidence. The healthcare design industry was a fertile ground for evidence-based practice, and the approach has drawn enormous attention in the field in the last 10, 12 years. There are many books published, articles published, and I mean, you can see the widespread kind of idea now. In healthcare design, specifically, which is constantly growing and transforming, EBD has a strong rhetoric in favor of reinforcing and utilizing scientific evidence. The context, which is briefly summarized in the slide, I mean, this is again a fertile ground for utilizing research evidence, and we can see that EBD is flourishing in the field of healthcare design. Following studies conducted in healthcare settings, it is now being acknowledged that architecture is instrumental to improve quality of care. Andrea's presentation before this one was an example to that. And research outcomes have begun to influence the industry at various scales and levels. The progressive efforts have led to increased interest in using relevant research in everyday decision-making concerning the design of physical features within healthcare facilities. Evidence design method is becoming, again, very common in healthcare design practice. But the question is, what is EBD? What is evidence-based design? What is on the screen is the canonical definition coming from the textbook, is that evidence-based design is the process for explicit and judicious use of current best evidence from research and practice in making critical decisions. The question I ask here, and I asked in my thesis, is that what is the best evidence in interdisciplinary healthcare practice, which is very complex? This was the driving question of the dissertation. And in order to answer this question, I have conducted an ethnographic-oriented study, a qualitative study, and followed healthcare design teams in a period of 14 months, actually. The research I have formulated involves answering the primary question: what are the forms and varieties of evidence in healthcare design practice? There are also sub-questions involving the use and translation of evidence in these interdisciplinary settings, but within the scope of this talk today, I will only present and discuss particular findings coming out of this extensive observational study. In order to better understand the notion, the role and the use of evidence in interdisciplinary design settings, I conducted situated observations and interviews spanning over a period of 14 months. The case I followed is a replacement hospital project which was initiated by a private health system in the US. I call it PHSP hospitals, but all the names, individuals, and the organizations are masked actually. The design task was assigned to an interdisciplinary project team comprising of architects, interior designers, and a variety of consultants, including engineers, physicians, nurses. And from the very beginning, the team's commitment was to run an evidence-based design project and develop an up-to-date, world-class facility to replace the old hospital in Georgia. Very briefly about the methods. Data collection for this research involved visits to multiple locations, including the offices of designers and other consultants, the hospitals where the meetings were held, and the mock-up studio. The field strategies relied on, again, ethnographic observations, semi-structured interviews, and access to project documents, including email exchanges, memos, drawings, talks, online exchanges, etc. The idea, again, was to capture the forms of evidence that circulated within design discussions. So coming out of this research, I will talk about 4 major forms of evidence. They're not mutually exclusive, but this is how I theorized the existing evidence in practice as emerged from my observations and interviews. I should say that I have adopted a broader conceptualization of evidence in order to understand the structure of arguments posed by participants in design situations. Accordingly, here the term evidence refers to information or a piece of information in various representational forms that provide basis for a belief about a phenomenon, which in turn affects design decisions. So let me start talking about these 4 forms of evidence in practice one by one. The first form of evidence, I call it precedence, which is pretty much aligned with how we understand the concept in legal terms. Almost every physical environmental feature considered in the design process I observed was accompanied by precedence which either had been observed by participants themselves or was communicated in the form of narratives, published case studies, or research conducted in these environments. In the excerpt, for example, O3, the chief nursing officer in the process, part of the design team, the participant, refers to a feature that she'd seen in another facility, which was repeatedly mentioned during design development phases as the team developed the details for the inpatient unit. The chief nursing officer in this case frequently invoked precedent cases to reinforce the statements which eventually influenced design decision making. If it works somewhere else, it's going to work with us too. That is the reasoning process. Either in the form of best practices from industry or local cases, the precedent suggested a set of evidence in action, I call it, to support or refute particular design ideas considered throughout the project. As the design progressed, the set of precedents was collectively assessed, contrasted, and represented in a variety of media, and was eventually crystallized and translated into the architectural drawings as the team approached the deadline for the project. The second form of evidence I will be introducing is the scientific research. Although evidence-oriented practices typically promote scientific evidence as the major support for design decisions as compared to other varieties of evidence, the use of scientific research providing sound and credible evidence to influence or challenge design decisions has been limited in healthcare. This was also the case in the process I observed. We found that claims about evidence from scientific research circulating in the form of loose statements without any specific reference to a research study. These statements, as they occurred in the exchanges within the group, pertain to particular design features at different scales, ranging from handrails in patient rooms to configuration of individual departments. The quotations I provide here in the slides uh, coming from the participants observed or interviewed, display a typical reference to scientific research evidence where the actual sources of that particular research, the context or the details of the findings were largely missing. They have an idea, but not that specific. Here is here for example, D1, uh, the chief designer of the hospital, is clearly referring to the famous Ulrich study published in the Science Journal. When asked, he was unable to provide an explanation for this piece of information. Where is it coming from, or the source of it, or the authors, or the details of the research? They were not there. But there is this idea of how views or natural light helps patients to recover. Scientific research, whether providing evidential support or not, offered the themes or issues to be considered within the interdisciplinary team. Rather than providing the definitive direction to pursue, it was just providing uh, the larger themes that the interdisciplinary team needs to discuss and decide on. Eventually, what we can observe on the end product, which is on the right-hand side of the slide, that the design team was able to incorporate the available evidence emerging from scientific, academic caliber, let's say, research. The third variety of evidence, anecdotes, uh, we also frequently observed in practice. Within the frameworks of evidence-oriented practices, anecdote has been characterized as the arch enemy. So, the anecdotes or the intuition, it's not the case. What you should rely on is the scientific research, that is the theory. In the practice observed, however, the anecdotes were seen to accompany design decisions at all scales, whether or not there was evidence offered by the available scientific research. The analysis demonstrated a key role for this anecdotal evidence, however, as it is used in practice, which is observed to be critical in maintaining interdisciplinary communication and practice. The anecdotes, whether or not reconcilable with scientific research findings, were employed to situate information or evidence emerging from various sources. So it has a role. Two quotations, two excerpts coming from our interviews, which were influential in the configuration, the decision made on the configuration of the emergency department. The case of developing the design of the fast track area in the ER, the emergency department, emergency room, which was initially designed to accommodate both adult and children, demonstrated how anecdotes facilitate simple and direct decision making in architectural design process. The configuration of space was considered following an anecdote introduced by a participant. Following the excerpt, the proposition was rapidly acknowledged by other participants, including the project architects, client representatives, and other staff members in the room. The decision, which involved spatial separation of pediatrics from adult patients, was quickly made and was never revisited again as the interdisciplinary team progressed through the design development phase. Another variety of evidence I'd like to introduce is, I call it embodied evidence. Different from the available precedents, provided first-hand experience for the participants. I call it embodied evidence, but you can call it in-house evidence too. This kind of evidence, which was not in place at the outset, was initially generated through a series of in-house experimentation, that is mock-up exercises, by the way, which were strategically created by the architects of the project. By their very nature, the mock-ups utilized in the project allowed participants to modify the initial layout only for a given set of constraints, of course, further experiment and tune the configuration to fit their needs. In this sense, the mock-ups enhanced the interdisciplinary interaction between the design and the participating parties, and even between the members of the larger community who are visiting the mock-up studio and providing their feedback. And in turn, it facilitated a collective action for problem identification and solution development. As opposed to other media, the mock-up exercises were collective experiments which led to a generation of first-hand evidence involving actual staff members enacting their everyday practices in physical space. The comments concerning the angle of the corridor wall for the patient room, for instance, were evaluated and re-evaluated by architects by using movable walls before the right angle was translated into drawings. The engagement of all parties here, we're talking about a large inclusion, nurses, healthcare workers, doctors, managers, etc., deciding in the formation of the inpatient room was very critical. Without updating the computer drawings after each tweak, as they call it, in the mock-ups, in this episode, architects' strategy was to wait until the group of practitioners reach a consensus, provided better visual access to patients through this wall, and until the angle of the corridor wall of the patient room was reviewed and approved by staff members, the mock-up remained as the major representation form to be manipulated and worked on. For a long period of time, the mock-up remained as the center of attention. Then the specific configuration of the wall was translated into CAD drawings, and this is actually what I label as in-house experimentation, or maybe generating local evidence in the absence of scientific research about the issue. So following the following the brief account concerning the four modes of evidence in practice, let me briefly focus on a particular mode of reasoning in this case, where these varieties of evidence come into play and are used to support design decision making. I find this particularly important since this mode of reasoning is kind of different for design decision-making processes, because in typically, or in most cases, design reasoning is about, or it relies on intuition, analogies, concepts, metaphors, or you just listen to your hearts, like Andrea talked about. But it is interesting to see such a reasoning process to fully justify your design decisions when you're designing for healthcare spaces. What I'm talking about here is the reasoning process, causal mechanistic reasoning. The reasoning processes suggested by participant statements that we observed parallel the mechanistic models within evidence-oriented practices in medicine. In simple terms, mechanistic reasoning that I talk here is characterized as a particular mode of cognitive operation, linking inputs to outputs, let's say, occasionally involving a step-by-step explanation of the black box between the intervention and the outcome. Like, if you design the ER this way, it will lead you to a better safety metrics and patient satisfaction scores. Or if you include such and such features in your HVAC systems or in your patient rooms, you will end up with reduced infection rates or airborne contamination rates, which eventually provides a safer hospital design. In each step, you can see a justification for your decision processes. I value these models as introduced by participants because these mechanistic models act as repositories of transdisciplinary knowledge involving design, medicine, epidemiology, nursing, engineering, etc. And they expand the scope of traditional understanding of evidence in healthcare design. So it's not only research findings, but a whole range of things coming from different disciplines. The figure here I present in the slide juxtaposes three chains of reasoning processes, one adapted from medical literature, the first one, and the two grounded in our observations, which progress through segments linked by causality. The second chain involves a decision concerning a particular feature for the mechanical systems that hypothetically leads to low levels of healthcare-acquired infections. The third one, on the other hand, coming from the case of emergency room design, the layout in an intervention, the change of the configuration of the unit leads to, in a causal fashion, improved safety and satisfaction levels. For all the reasoning chains presented here, the participants were observed to include or integrate evidence coming from various sources. Also, of course, including anecdotes, embodied evidence, scientific evidence, and precedents. But the problem here is that these causal mechanisms chains are not always full. Obviously, not all mechanistic reasoning is created equal, and these models suffer from partially understood or missing links. Accordingly, the segments within this causal links in engineering and architecture were not fully supported by scientific research, so they do not strongly suggest a complete and reliable model for decision making. The overall structures of the two examples below provided in the diagram were created, maintained, and propagated within the community of practice that I observed, and were observed to permeate design thinking as architects or engineers introduce complex interventions involving knowledge coming from an array of disciplines. This is, in a nutshell, how the evidence was employed in both reasoning and design processes. So at the end, I'd like to emphasize 4 points here. Hope this quick introduction was clear for you all. First, the participants of the interdisciplinary team were observed to employ the full range of available evidence, not just emerging from scientific research as suggested by the evidence-based design framework, in order to formulate and explain their ideas in terms of mechanistic models to form causal links. Again, we're talking about an extended notion of evidence to include precedents or in-house experimentation evidence, let's say, or anecdotes coming from the practitioners, meaning nurses or the healthcare workers who are on the front line. The second thing I'd like to emphasize at the end is that the developing rhetoric of evidence-based design, particularly in healthcare design, proposes a model of practice where design decision-making is continuously accompanied by a form of causal mechanistic reasoning in which space is considered as a variable that affect outcomes. The third thing I'd like to say very quickly is that when available evidence falls short in this causal links, causal mechanistic links, there is a tendency to generate local evidence to complete the chains of causal reasoning processes in design decision making. In this case, the mock-ups, one-to-one scale prototypes we're talking about, as a distinct form of architectural representation was instrumental, at least for this case I observed, to generate and maintain interdisciplinary interaction and decision-making processes. And finally, these causal mechanisms, by their very nature, accommodated problems that occasionally forced participants to reason behind their particular disciplines. That is where we can observe real interdisciplinary interaction and reasoning, collective reasoning processes. This is very critical considering the intentions to achieve inclusion or integration across participating disciplines and domains in healthcare design decision-making processes. So very quickly, what I wanted to say was this